Our next presenter will be the moderator. Well, our moderator, I'll be presenting our moderator for the next presenters. All right. A licensed pharmacist with a graduate degree in pharmacy for over 20 years. Highly organized and efficient. Strong presentation skills. Currently, she's a lecturer at the clinical preceptor, an inpatient pharmacist, supervisor of surgery at the University Hospital of the West Indies between 2010 to 2016. A preceptor coordinator, pharmacist externship at the hospital rotation clinic. Certified specialist in HIV pharmacist at Mona UA Hospital 2015 to current. Chief pharmacist for Charis Pharmacy from the year 1993 to 2001. A little of our brightness now. In 2014 to present, Robert Gordon University, Aberdeen, Scotland, a Masters in Clinical Pharmacy. 2007, University of Queens, Brisbane, Australia, Master's degree in Pharmaceutical Sciences with distinction. You had to say that? UTech, Mona, the first step, or Bachelor's of Pharmacy. She has done numerous presentations across the length and breadth of Jamaica, a member of the PSJ, a consultant to the Continuing Education Committee of the PSJ also, former chairperson of the Creative Arts Group, Richmond Park Church of the Nazarene. Yeah? Cool. She's married to Dr. Victor Elliott, my doopstat, I'm a brethren, and the proud owner of two highly intelligent and give plenty trouble boys, Jonathan 12 and Mason 3. She's bubbly, she's witty, she's effervescent, she's cool. Please welcome Miss Sarita Anne-Marie Campbell Elliott.
Well, it is my privilege to be here with you today, and without delay, I'm going to invite our panelists to just step forward for me. Dr. Merton Smith, Dr. Jennifer Bent, Dr. Michelle Russell, and Miss Elena Langley. Now, I'm sure I'm going to have people stepping out of their seats this morning, right? So I'm going to crave your indulgence, and I'm going to ask for temperance. The objective of this session is to share our perspective, and at the end of the session, to develop strategies so we can move forward. I say that, I preface by saying that because I also don't want you to be quiet. We need to articulate our concerns. We need to engage each other, but we need to do it with respect and with purpose. True? Yes, I'm a teacher too, so yeah, I like to hear responses. Yes? Okay. So I'm going to briefly, since we're hard pressed for time, I'm going to briefly introduce our panelists today. I'm sure everybody heard that, right? So we're privileged this morning to have Dr. Merton Smith with us. Dr. Smith has completed his MBBS at the University of the West Indies. He went on to complete his doctorate in medicine and in ENT surgery. Over the years, his practice has spanned various hospitals, both locally and internationally. He has practiced in the UK and in the Cayman Islands. He's actively involved in training, as is typified in his CV. He is a consultant at the University Hospital of the West Indies, as well as an associate lecturer with the University of the West Indies. He's also committed to serve. And as you saw from Dr. Matt Daniels' presentation, that Dr. Smith is involved in various aspects of not just regulation, but ethics. He is, as I'd mentioned, consultant at the University Hospital, associate lecturer, but also of note is that he's a present trustee of the Jamaica Medical Doctors Association. He's the president of the Jamaica Association of, I have to slow down to get this one, otolaryngologists. Yes, Dr. Smith? Okay, I did it. He's currently the vice president of the Medical Association of Jamaica. I'm sorry, I apologize, Dr. Smith. He's currently the president of the Medical Association of Jamaica, and also the president of the Association of University of West Indies Medical Associate Lecturers, and the president of the University Hospital of the West Indies Medical Consultants. And I'll move on quickly. I met and briefly spoke with Dr. Bent this morning. Of course, I'm still in stitches. An amazing individual. Dr. Bent, after completing N1 and N2 at the university, transferred to Chelsea College in London. And while there, she received a scholarship to the Clinical Research Unit at Harrow, London. She started research at TMRU. We're familiar with TMRU, or now TMRI, at the University of the West Indies, and with an interesting topic of research: intracellular electrolytes and sodium pump rates in patients undergoing open heart surgery. That is more my husband's, not mine. But she also presented this paper, and this speaks to her passion in what she does. She presented this paper at the Commonwealth Caribbean Medical Research and was accepted into the Faculty of Medicine in that same year. After graduation, she started her practice in 1984. I apologize for aging you, Dr. Bent. You don't look at the age. Not over 30, not a day over 30. She's also a founding member of the Caribbean College of Family Physicians. And what I found was intriguing is that each member requires 50 CE hours for every 3 years. Every year, she clocks 239. When I grew up, I want to be just like you, Dr. Bent. She continues to proudly represent Jamaica and the Commonwealth Medical Association on the international scene. She has done work in women's health and maternal and child health, and has left an international footprint. An outstanding contributor and advocate for family medicine, she continues to contribute to the development of our society. Miss Elena Langley. Miss Langley, I can't say that's a teacher, right? Yeah. Nobody would believe me anyway. After completing her bachelor's in pharmacy at UTech, she has practiced in various areas of pharmacy. And that includes community pharmacy, manufacturing, and is now in regulations. She has been an inspector and a trainer and educator, and is currently the technical secretary of the LIST subcommittee in the Ministry of Health. She sums up, and I like this, she sums up her daily objective as this: to gain further experience in her career field while being an asset. I like that. While being an asset in the delivery of pharmaceutical and general healthcare services, in the furtherance of the practice of our noble, and she made sure that was clear, our noble profession. Now for the next panelist, I could just ask her to come and introduce herself, right? Yeah? And everybody start to smile, Dr. Russell. Dr. Russell often shares that she has lived many lives. You believe her? And it is reflective in her very pragmatic disposition. She's open, she's honest, but she has an amazing heart that cares for her patients. But all of that is wrapped up in a little comedy, right? After completing her studies in pharmacy at UTech, she went on to complete her PhD in pharmacy at Hawaii University in 2007. She has always shared, ever since I met her, she has shared a commitment and a passion for three main things: community and her patients, the evolution of the pharmacy practice, and the education of pharmacists. And if you know anything about Dr. Russell, she's involved in everything from presentation of CEs and at seminars. She's involved with pulling you in the corner and saying, no, that isn't right. No, man, maybe you should consider this. And so the span of her education and involvement in all of us is widespread. Now, I'm not going to take up any more time because I think the experts are right here. Before we begin into the very vibrant discussion that I know we will have this morning, I would like to ask our panelists to just share from their perspective, in just a few minutes, to share from their perspective how they see the collaborative process is unfolding in our society between pharmacists and physicians. And I'm going to first invite Dr. Smith to share with us first, and then Dr. Ben will go next.
I am, being a member of the medical fraternity, we're not used to seeing so many people turn up so early for a function. Doctors are very, we're a different set of creatures. So I'm very surprised and pleasantly so at the turnout that you've managed to accomplish. I think this is in fact a very good initiative on the part of the Pharmaceutical Society of Jamaica to have this kind of discussion, because I think, as healthcare professionals, we have to work together in the interest of our patients. Developing a collaborative working relationship between pharmacists and physicians, I don't think is as far-fetched as it might at first seem. It is necessary and essential if patient care is to be optimized. While each professional group, we have our separate training and our different skill sets, and therefore we have our different roles. In many instances, we have to work together in the interest of the patients. The pharmacist cannot be seen as merely a dispenser of medications, but the pharmacist is very integral in patient care, and they must help to ensure at least some of the following: patient safety. The pharmacist must provide a second level of checks and balances to ensure adequate dosage and frequency of administration of drugs to be taken by our patients. And we've heard several examples, certainly of where, errors were made on the side of the pharmacist, but I can tell you several examples of where errors were made on the side of the doctors that were picked up by the pharmacist, resulting in some correction of those errors, with the patient getting the benefit of the collaboration between the two of us. It is also important that the pharmacist helps to avoid drug interactions based on the pharmacist's knowledge of the patient's drug history or the combination of drugs that are on the prescription that is now being processed. Another thing that pharmacists must help with is patient adherence and compliance. Pharmacists must also play the role of counselor to advise patients on the importance of taking drugs as ordered. Pharmacists must also play an important role in sourcing medications that are affordable yet of high quality. Another thing is patient honesty. Pharmacists provide another level of checks and balances to help to prevent insurance fraud. And the case that Dr. McDaniel highlighted for us clearly highlights a well-known issue here in Jamaica where people try to get prescriptions written in somebody else's name so that they can use their health card. And indeed, This is something that we remind our doctors of daily, that even though you're trying to help, it is insurance fraud and should not be done. And so the pharmacist, we think, lays another level in checks and balances. What are some of the concerns on the part of the physicians? So some concerns that have been raised include pharmacists substituting the drugs that are prescribed without communication with the physician that is prescribing. Now, this is acceptable only if the physician did not put their contact details on the prescription, which is another thing that we've been talking to our physicians about, ensuring that they put their contact details on the prescription so that they can be contacted in the case of any errors or any concerns. Another area of concern is changing the physician's intended duration of treatment without consultation with the physician. So that happens with me as an ENT surgeon, where I prescribe an intranasal steroid spray for 6 weeks, and the patient tells me the pharmacist tell them to take it for 2 weeks and stop. And the pharmacist did not call me to say, well, what is happening. I mean, obviously this is what the patient tells me. I wasn't there at the window when the patient was interacting with the pharmacist. And another concern that some persons have raised is the thought that patients go to a pharmacy to get a medication, but because the pharmacist is not familiar with a particular usage of that medication, then they just decide not to dispense it without communicating with the physician. So these are some that have been raised. What are some of the steps we feel in helping to help us, get on the way to working together? Conferences such as this. So this is one good step. The role of the medical council and the MHA in reminding physicians to adhere to the proper ways of writing prescriptions, and we continue to do that. Just this week we sent out another reminder to members about some of these things, and I know the medical council does that on their website as well. The role of the pharmacy council in reminding pharmacists on the need for dialogue between doctors and pharmacists. So how can we facilitate some of these linkages, some of these collaboration, having links between pharmacies and physicians' offices that are nearby? When I was in Ligony, there was a pharmacy that was right next door, and we had a very good working relationship. We had both written material and verbal communication. So there was a very close working relationship between our medical practice and the pharmacy. And I think that augurs well for the working relationship between physicians and pharmacists. Digitization of prescriptions. We know that there are at least 4 groups in Jamaica now that are developing platforms for e-prescriptions that can be sent to pharmacies and then for the pharmacists to dispense. Obviously, we may have issues in working out the medical legal aspects if MAGIF doesn't cover in the event of telemedicine. But certainly it is a way that we can share information on the patient electronically, including the patient's medical history, drug allergies, and previous drugs that they have taken, and this can help to improve accuracy and reduce errors. Changing attitudes towards each other through education and communication and health promotion campaigns. And I think that it is essential that we have to work together on very important national issues. One important one that's coming up now and is in the media is marijuana and medicinal marijuana. I think the pharmacists should add their voice to this one, because our concerns from the medical fraternity has nothing to do with trying to block the Jamaican public from getting the good collie weed and gaining from the export of the drug. Our concerns are what will happen to especially our young people, the vulnerable people, when they're allowed access to marijuana, especially things like the edibles and things like those that release a high dose. I think the Pharmaceutical Society should join us on talking on this matter. And last, I'd just like to close by saying again that I congratulate you on organizing this meeting where we can hash out some of these issues, and I look forward to the discussion.
There was a newspaper article a couple of weeks ago, a Sunday newspaper article, in which the pharmacists were protesting about filling prescriptions from doctors who did not sign properly and who did not have a registration stamp. And they are leading the way in trapping people who don't really want to pay registration fees and are trying to function outside of the parameter, right? It is very, very important that we work together, because we communicate with each other for the benefit, effective management of the patient. And it is valuable. In my little town where I practice, I have a gentleman called Mr. White. And I am constantly on the phone. Sometimes when I pick up the phone, I say, Lord Jesus, I wonder if he's fed up with me. And I saw Mr. White registering this morning, so I know he's here. Failure to find him, even in his bathroom, I call a pharmacist in Kingston. And I said, check this out for me. Check the dose. Is this compatible? I think just 2 days ago we had a conversation about medications that interact and extend PR, the levels on the ECG and that sort of thing. So we're very technical, and we can work together to help to give the patient the best combination of medications, to highlight interactions. And when patients come, and they come 2 months after the prescription has expired, and they say to me, I say, so how come you're hypertensive and you took your last dose this morning? Your prescription should have finished on the 15th of March. Oh, I got the pharmacist to extend. Sometimes you've only given them a 21-day trial period because what they were on before wasn't working, and they managed to extend it, or they show up without being on medication, and that just destroys the whole benefit of giving a trial period. When we started using drugs with the off-label use of the drug, for example, when we started gabapentin and all of those medications for pain, nerve pain, I had to interact with a pharmacist in Ligony who refused to fill the prescription for that because he said to the patient, do you have epilepsy? What he should have done is picked up the phone and called the doctor who wrote the prescription, rather than to plant an idea in the patient's head that would make the patient refuse to take the medication, right? I would prescribe the Combiwave pump with a mask, and the pharmacist is saying, you don't need a mask. Well, someone is really tight in the chest. When you attach a mask to the chamber, they breathe at leisure, and they don't need to have to suck with a tight chest. And that's the importance of it. Call me up, discuss it with me. Don't assume you know what I'm thinking. And sometimes you are my backative when I write something that don't quite click. Call me. Pharmacists are now required to give generic drugs. Quite often in our practices, especially if the drug house knows you don't sell free samples, I have a mountain of free samples I can start my patient on. Sometimes after the pharmacy is closed and they're still in the office and they're sick. Then you send them to the pharmacy with a prescription for the extension, and they get a generic. So you manage to bring down 104 fever to 100. 5 days later, when you recheck them, they're still 100. And you say, what did you get? And they got some generic that is not maybe an original generic after the patent was finished, but something 2 changes down the line, which does not work very effectively, and the patient still has a problem. So we need to pick up the phone and talk to each other, because when you tell me patient cannot afford a brand and you're going to use a generic, I said, okay, go ahead, tell them to check back with me for a free review in 3 days, and I make a note of what is used. Right? So then I get to recheck my patient to see how well they are resolving. There are lots of things in which we offer checks and balances and communication and learn from each other. And I'm glad that this collaboration discussion has started.
Good morning, colleagues. Right. So we've heard the perspective of the medical sector to some extent. I will be giving the perspective from a regulator. Now, we need history, we need context. So pharmacy first separated from medicine in 1240 AD. And interestingly, this was based on what was seen in Arab countries during the Crusades. Since this time, there has been a gradual shift in the environment where pharmacists, as Dr. Smith referred to, are no longer viewed as merely producers or dispensers of medicines, the hewers of wood and drawers of water. They are no more empowered to provide input concerning patient therapy, accuracy, efficiency, and quality of care. And certainly we can see this in more developed countries. In a sense, the disciplines have gradually developed interdependence to enhance and improve patient outcomes, which is the ultimate goal. So what about the current legislative or ethical framework? In Jamaica, there exists a shared legal responsibility for the care of patients. Pharmacists and physicians both have regulations which govern practice, as well as training. The current framework provides for the professional application of a pharmacist's knowledge in areas such as patient counseling, drug therapy, monitoring, and drug substitution, among others. The existence of the list number 2 classification, for example, allows pharmacists to assess clients and dispense medications based on their professional training and established guidelines. And this can be seen in Regulation 21.1 and 21.2. The pharmacy regulations continuing in Regulation 25 outlines the basic requirements for accepting and assessing prescriptions. Regulation 21.2 speaks to ensuring bioequivalence, which Dr. Bent just referred to, in dispensing prescribed items. Regulation 22.1 and 2, parts 1 and 2, outline the criteria for offering repeats based on prescription characteristics and not what the old man says about the eye drops. And finally, Regulation 22.3 outlines the necessary documentation for the pharmacist's dispensing actions. So documentation is important. Of course, our profession is not just hinged on legal responsibilities, but ethical responsibilities as well. And under Section 25J of the Pharmacy Act, pharmacists via the Code of Ethics are empowered to act in the best interest of the patient, which would see pharmacists examining, on the basis of training again and education, like what we're doing here, issues such as the cost of medication, patient compliance, and instances of adverse events, among others. It can be seen, therefore, as will be outlined, I suppose, as we go further, that a collaborative working relationship, I think Dr. Russell will cover this, we are basically maneuvering between stages 0 and 1 of the collaborative working relationship, in that both professional units, the pharmacists and the doctors, are aware of each other, and there is, to some extent, utilization of the basic aspects of this regulation. But what about the legislation and the implementation of this collaborative working relationship? Research points to a best practice of using scope of practice legislation. In other jurisdictions, it is used with the aim of aligning both education and operational policies. And this creates a synergy to promote collaboration and to make the best use of support staff. It can be recognized that the exposure of our pharmaceutical students in clinical practice to the implementation of pharmaceutical care, and as was mentioned previously, medication therapy management, as well as the facilitated interaction on externship and internship with medical students, interns, consultants, etc., has set the stage for the continued refining of the definition of a scope of practice for our pharmacists in Jamaica. We should also take note of the number of persons who are trained to the level of doctor of pharmacy, as this will also serve to enhance the implementation of the collaborative working relationship. A properly outlined scope of practice law will create an environment which produces a successful working relationship and the fostering of what we call interdisciplinary teams, the healthcare team. So legislation, education, and policies may further enhance the integration of pharmacists and the services which we provide into team-based care models. The broadening interaction, and this is important, may allow all professionals, both physicians and pharmacists, to practice to the full extent of their licenses and facilitate support staff taking on more roles. It should be noted here that the legal recognition of pharmacy technicians and the expansion of their roles in the healthcare team can facilitate the ease with which pharmacists can embrace a collaborative working relationship. Currently, our laws allow for the collaboration which is interdependent, hierarchical, and autonomous. An example, or 3 examples rather, the identification of medication-related problems which require the buy-in of the physicians to implement the recommended change, the ability of pharmacists to recommend list number 2 products as adjunctive therapy, the provision of counseling to patients on the use of prescribed drugs or treatment regimen. So how do we facilitate the development of a collaborative working relationship from a legal point of view? 3 points. We need to look at the legislation that governs the practice of both pharmacists and physicians in order to allow for the definition, building, and strengthening of these relationships. In other jurisdictions, they have utilized what is called omnibus legislation to provide the basis on which different members of the healthcare team and the support service sector can be brought together to facilitate implementation. This method has its pros and cons, and so it would have to be examined within our context to see what works best. Secondly, the facilitation of interprofessional dialogue, as what we're having now, as well as other levels, between members of the healthcare team may serve to craft protocols which govern the implementation of the working relationship and therefore help to enhance the development of a scope of practice law. And finally, it should be noted in the pharmacy regulations that there is a provision in Regulation 22.4 for pharmacists to be remunerated for the provision of services to the practice. The inclusion of compensation in crafting a framework will require the participation of associated services such as laboratories and insurance companies. These relevant stakeholders should be included in the process, which may allow for the aligning of incentives and reimbursement for all healthcare team members. This aspect will aid in the cost-effective improvement of healthcare delivery and ultimately enhance patient outcomes. So it can be seen, therefore, that the continued effectiveness of healthcare teams will be enhanced by the use of legislation which clearly outlines the responsibilities of each individual team in a collaborative working relationship, and this will serve to guide the role which each member of the team plays. Thank you.
This works now. I'm going to give you a 50-minute presentation in 5 minutes. Yeah. You know I have those skills, right? Yeah. Okay. We don't need to look at the objectives. Can you see that properly? Really? I'm so sorry. And this is not a touch screen, so I'm there. Can't help you with that. The areas in which physicians collaborate with pharmacists to provide patient care. A survey was done, and this was basically the result of it. What they were saying, 19% said to receive advice regarding modification of a patient's drug therapy, dosage adjustments, management of drug interactions, decision-making regarding a patient's drug therapy. We often get calls. I have a patient, and I say we, because we all do, because there is at least one physician near us that will call us. And it is of note that, as Dr. Smith said, the closer you are, is the more likely you are to get a call from that particular physician or for you to call them. We don't really have much to do with insurance coverage in Jamaica, but a lot of doctors in the States see that as one of the main functions of the pharmacist. because over there it's an automatic generic. If you want brand, it has to be requested and a phone call has to be made to the insurance company. So the working relationship moves from stage 0, which is professional awareness, to commitment to working together. And there are a whole heap of little things in between. Professional recognition, again, the proximity will cause that. Let's have a trial and error here. Let me see how me and this pharmacist can work, or this doctor and I now go work out, you know. There are some doctors I don't call. I'm admitting it. I'm not going to call them. I'm not calling anybody who is going to be rude to me. And I'm sorry, I'm not recommending that anyone else does what I do. Please, anybody who has been my student will know, do as I say and not as I do. I have been practicing a long time and I have a lot of relationships with a lot of doctors. You have to know who you are talking to when you are speaking to a doctor. So how I speak to Dr. Vint? Jenny, you just reach work? Why you write this? I don't know Dr. Smith. I've never spoken to him before, so the first time I sent him a little text, I was very proper. I said, I say, Merton, my name is Michelle and we're on a thing together, you know? We need to meet. Or, Dr. Smith, my name is Dr. Russell and we'll be on a panel together. I'm sending you the slides. So I decided to let him take the initiative. So I did a fairly professional text and he responded fairly. It's me, let's get real. And he responded quickly and he didn't sound stiff, so I felt comfortable. You know, I still never called him Merton, but I thought about it. All right? So, we know, I think I know, now that I've met him and I've texted him and emailed him, I feel like I know him. And I feel that I could pick up the phone and call him without fear of, who are you again? What? If I wrote that, that's what I want. Now you see, Jenny write the inhaler and then she write the thing. So I call her and say, I know he's an adult, but why you want him to have a spacer? And she says, well, he has COPD. He can't breathe. Oh. Yeah. So you need to know who you're speaking to. You don't just assume that the person is wrong. And the next thing, when you make the call, please do, God, have an alternative. So, Doc, Shudarma, sorry. Let's use a nice Abbott product. Cari-Med is out of stock. What can I use? What covers that bacteria? You look so fool. You got to do it. And if them call me when I'm on the road, what is the maximum dose of chlorpheniramine? Oh, Doc, I'm driving. Let me pull over. I'm not driving now. But I need enough time to look up Medscape app or Hippocrates or whatever you use. I'm counseling a patient. Let me call you back in 2 minutes. No doctor ever tell me no to that yet. I'm telling you secrets here. But you understand where I'm coming from? You need to look professional. You never ever, my students will tell you, never ever tell a doctor that you don't know. You make it your job to find out in the next 15 minutes. That is how you look like you know. That's why they think me bright. Because you can't know everything. You need to recognize that you cannot know everything. All right? So, who are you dealing with? The individual's characteristics, your personality. That is going to be important when you're dealing with somebody. You will have people who will laugh and smile with you. I don't know if you ever call Dr. Persad, but I don't hang up without getting a joke. He always gives you a joke. After you correct the prescription, you know. Alright? So you have another doctor who will be just quick. Okay, oh, I'm sorry. Could you change that to 250 twice a day? That's it, done. So you need to know your age, the age of the doctor and the pharmacist and their education. you find sometimes that younger doctors tend to be a little bit more relaxed or nervous. No, I said or nervous. As they get older, they are more accepting because they realize that the role that we play is an interdependent role. Yeah, some of the young ones can be a little bit arrogant when they come out. Yes, but then aren't we all? Yes, man, when my students come and they're ready to school me, and I just wait, and then go look it up, and then I get, because I have to go look it up, you know. I don't remember everything. Your knowledge, your attitudes, and your beliefs will also affect how you interact. Right? I believe that this doctor faced the outer order. Therefore, when I speak, my tone is different. It's not as relaxed. And immediately that sets the tone. I remember working in a pharmacy in Florida. They had all these stars behind the people's name. So I said, what is that for? And they said, oh, those are the patients that give trouble. I was so upset. And I set out to teach them how to talk to patients. And the patients who had the most stars I was their favorite pharmacy student in there. Because why? You just talk to your patient. You don't look at people and say trouble. Okay, there's one or two. But you don't want to see what I put beside them name in the thing. All right? Your professional experience. The more experienced you are, is the more you will interact. The proximity of practice, we have already established that. The volume of exchange. The more you exchange, the easier it is. I call downstairs without even thinking. I call and say, it's me again. And then I don't even have to identify myself. When I call the doctor's office, I say, it's me again. They know who is calling. What are the features of the practice? Is it an isolated pharmacy? Are the doctors far, or are they in the same complex? Because that again is going to affect the working relationship. So a single physician is more likely to collaborate with pharmacists rather than a big group. So if you take let us say you have 8 or 9 doctors in a practice, they're more likely to interact with each other than to call a pharmacist. They'll call for prices and they may call for other things. I had the privilege of working with a group of doctors once or twice, part of the requirements for Ohio State. And I got called in, and you know, we're all huddled in this room trying to find the right thing, and I felt so important. But the reality is, if I wasn't there, they still would have met without me. They might have called me after. But the reality is, it's very good to be in that sort of relationship. So we have complementary roles to improve patient outcomes. It improves drug history taking. They go to Dr. Smith and them tell Dr. Smith, you're taking it? And we are treat my ears, need to know that. We see that all the time. Their partner gives them a prescription, which they don't mention to their GP, because they didn't go to the doctor for that, right? Right? So, improved prescription error detection. The other day, one came and I couldn't figure it out, so I just wrote a note on the back, you know. You learn that at drug serve. You write a note on the back, you send it back to clinic. And as the man said, I should take it, she knows she writes something right. She said, oh dear, I wrote that. That's the patient reporting that to me. Right? Because I looked at it and I called 2 doctors before I write the letter, do you know? Because I have that sort of relationship. It increases our knowledge skills. We can call. That is how we learn to be better clinicians. Dr. Ben will tell you, I called her the other night, the man said, walk up the stairs and he can't breathe. And his GP tell him that when he stopped smoking, he couldn't breathe either. And this is going on for a week. And the man have a history of pulmonary embolism. So you know, I started getting nervous. I was talking to Dr. Wilson Clark on the phone and she said, she could hear because I had on a Bluetooth at the time. And she said, you're not sending that man home, right? Well, when he went, he actually They did all the tests. It was not PE, but he had actually had potassium and sodium deficiency. So he ended up being on drips the whole day. But you understand? Sometimes, as I love to tell you, talk, man, talk. All right. This was a study that was done, and these are the points that they thought that would determine how well a physician interacted with the pharmacist. It was about recognition of roles, expectations, communication, trust, mutual respect, and a willingness to work together. How do we perceive our roles? So, how a doctor looks at a pharmacist is not how a pharmacist looks at a pharmacist. Physicians would like to collaborate to improve patient adherence and support, whether insurance to make sure that the prescription is correct, whereas a pharmacist would like to provide more support in identifying and managing patients' drug-related problems, because the training that we got when it was KPH chemist is not the same that we're getting now. Our role has expanded, and we want the recognition for that role. How are we going to get that recognition? We have to work together. One of the problems, as Julie so happily reacted, is a lack of compensation. Can't bother. Why should I bother? I not get no money for this. I'm overworked already. Some days I don't even get the 4 15-minute break I'm supposed to get. They don't have no time. And the reality is, it's not one doctor or one physician or one pharmacist. There are hundreds of them. And on any given day, you may have 30 or 40 different physician prescriptions coming in. Maybe more, depending on where. So, as Ms. Langley had said, future research is necessary. So we need to improve our communication. We need to document, standard documentation. No more them and us. Interdisciplinary communication. I want you to know that as still the chair of the Continuing Education Committee, it is my dream to have a interdisciplinary seminar. And I'm working on it, you know, and I'm going to try for next year. Hold me to this. As long as Medical Association and the Nurses Association and maybe Dental Association, I am going to pull off that. It is my dream. And we want this turnout. That was from Ainsley, you know that, right? All right. There's not so much of a hierarchy in pharmacy as there is in physicians, but if you communicate with respect, you will avoid negative perception of the other's role. You must build trust and accountability. I wanted to leave up this slide because it shows, you can go and look at it closer. This is just a slide for later about where we can collaborate and where the physicians thought it was needed versus the pharmacists. Thank you.
Thank you so much to our panelists. And we're going to move right into the discussion. This research is of particular interest because in this particular research, over 90% of the health professionals said, listen, hey, we're willing to work with each other. And when they actually checked how many, less than 10% actually did. So the thought is there, the heart is willing, but we're not actually executing this as a practice. I'm going to open up the floor. What I'm hoping, we're hoping to get from this session is for individuals to share some of the challenges they have and for us to come up with some strategies. We don't want to leave here the same way we came today. Do I see any hands? No hands? No discussion? Please, I'm going to ask you to move quickly to the microphones that are in the aisle.
Oh, pleasant good day. It's past morning now. I've been listening to all the presenters, and I'm very happy to say that all of you did very well in putting forward some very interesting and important points. All, if we put them together and we really decide to work together, we could achieve much. But I sat there and, quivered at something that we seem to forget sometimes. And it's this, that people, need to come together first. Need to break the ice, get to know one another, and get to fellowship. And then, you create that baseline where you want to meet and greet, and then discussing your professional or your business becomes a 1-2. So maybe we could look at the Medical Association and the Pharmaceutical Society of Jamaica, plan a few sessions, a few parties, a few get-togethers, and look at soca sessions, look at this and that. And, share a few drinks and talk about these things. Sometimes we're too stiff and too straight. And, I say to pharmacists about, you organizing yourself on a local level. Do you ever spend the time to meet at a bar or somewhere? Whatever, meet as 5 or 6 pharmacists and just relax and talk about your life and so on. And say, where we want to go with our profession, where we want to go with, getting some more money for work or more recognition for a thing. Start with that, because a lot of us can flesh out the real problems and learn to work together. But if we never get together, it's not going to happen.
Thank you very much.
When you first come into the area as doctor or pharmacist, take a little walk over to the office and introduce yourself. It would smooth the wrinkles tremendously. I am so-and-so, this is my qualifications, even for other doctors coming into the area. I keep telling them, I came to Linstead as a district medical officer, and at the time I came out, the clinic was supposed to be servicing 79,000 people. I tell them if anybody gets a typhoid outbreak, I go to the beach in Ocho-Rios, because I never do medicine to commit suicide. But you need to be able to interact with each other, right? And you get the meat of the person when you look them in the eye and you meet them face to face. I'm a young pharmacist, I'm coming from so-and-so, and I don't know where pharmacists go to learn how to read doctors' writing, but there must be a part of the course, right? But as the gentleman spoke about interaction, first meet the person. When you come in or when the person comes in, and that will open the road.
Absolutely. I agree with the comments, because what it does, it breaks down this barrier and this fear. I'm not sure how many of us, the first time we've had to confront a physician face to face, you think that, oh, I have to be careful of what I say. I'm not sure if I'm going to be accurate. This fear and anxiety and anticipation that we build around an interaction, we can break that down. I really think that we need to have these collaborations. Absolutely. Next question.
Good afternoon. I like the panel because I'm sure that somebody will give me an answer this afternoon.
I'm sure.
I work in the rural areas, retail pharmacy. One of my biggest challenge is the doctors who work in the area, the private doctor, they stock medication, most times far more than you are stocking in your pharmacy. Because what they do, they see the patients, and after they see the patients, even with the patient having their insurance card or the NHF card or whatever, they still get their medication from the doctor's office. So it's one of our biggest fights. What can we do about this?
And I can see the look on some of my colleagues' faces that, oh Lord, she's going to say it. Yes, I'm going to say it. As pharmacists working in the wholesale or distribution sector, we have a responsibility to ensure that we're not only providing stock to doctors in order to carry out their function or their practice, but we need to also put some thought into it. If you have a cardiologist who is using on regular 30 packs of Resilo and he orders 120 packs, that's a red flag. Take up the phone, call him, find out what is happening, and impart the knowledge to that physician that you are really managing the patient, you're not treating the patient, and you're doing a disservice to the patient if you're supplying the patient with medication. There's a reason I started off my presentation by saying that the professions were separated. There needs to be some checks and balances. And as community pharmacists, we are aware of a lot of the doctors who are, for want of a better word, stocking medication. And we need to communicate that to the Pharmacy Council as well. There is a collaborative effort between the Pharmacy Council, the Medical Council, the PSJ to some extent, and the MAJ, as well as the Pharmacy Council has dialogue with the Ministry of Health because they license these doctors who practice in medical complexes and so on. So there can be action which is taken, but first we need to interface. A lot of times persons are, and when I say persons, I mean physicians, they're dispensing these medications, and I use the word dispensing because that's what they think that they're doing. The law says that they're supposed to supply, not dispense. So if you are treating a patient on Friday, you give them enough medication to last them until Monday, when they can go in and actually fill a prescription. You can't have a receptionist, you can't have an office attendant giving prescription medication to a patient. I trust I've answered that question appropriately. Is there something that I left out?
All right,
Excuse me.
For me, I find that a very, very sore point because I think that doctors need to, as we like to say, stay in the lane. I don't see why a doctor would want to take on the issue of dispensing drugs.
Where are you from? Oh my God.
All right, well, certainly I can say that from my standpoint where I'm sitting now, for the next few months as president, I will certainly use the opportunity to reach out to the members of the association and doctors in general to remind them that this is not part of the core function of a doctor. And in fact, I remember in medical school, when we used to have our talks on ethics, there were a lot of discussions about the conflicts of interest with doctors owning pharmacies and also being the ones, prescribing and sending the patients preferentially to their pharmacies. No, I think that this is, I think this is certainly an even greater bastardization of the whole thing, and so certainly something that I will use my current office to remind the members about, because I don't think that it is right.
Yes, thank you so very much. Just speaking as a member of the Pharmacy Council of Jamaica, we have recognized the issue, and we have gone to the point of meeting with the Medical Council of Jamaica, to the point where just last week we had our exec meeting, and another letter is also going to be issued to the distributors or local distributors as it relates to the amount of medications that are being supplied to the physicians. We understand that the physicians need medication in order for immediate treatment. That's very important. But however, this wholesale stocking of medications is an issue. It has implications for patient care. It has implications for management of chronic illnesses. It has implications that are far and varied, and so we're taking on frontal. Thank you.
Just on the same thing, Pharmacy Council. What happened, I am in the situation that I know exactly what I'm talking about. You come to the pharmacy and we are scrutinized, everything. We have to have everything on par, everything according to what you want. Yet these people, when you go to the doctor's office, the people who are serving there have nothing on par. Sometimes when you see the labels from the people who bring them in, sometimes when you see the bottles that they put the things in, it is so bad, and yet we are being chastised, we follow all the standards, and there are other people who are out there not following anything, making far more money than us, and nobody is troubling them.
Just to allow me to respond quickly, because I'm actually responding, and I'm actually responding on behalf, and I just say behalf of Medical Council, because I had 2 sessions. Pharmacy Council with the chairman, Dr. Dunn, had a session with at least 3 to 4 members of Medical Council. The registrar of Medical Council says, write them about any physician who is practicing in a way that is not in accordance with the Medical Act. 1, put it in writing, send the evidence. 2, he also says, and he not just said it at the Pharmacy Council meeting, he said when I presented to the Association of Consultant Physicians, he was there again, and he said, any physician, he spoke about conflict of interest, right? Whether it's even a doctor who has a problem, right, the Medical Council, let them investigate. The challenge they have, unlike the Pharmacy Council, they don't have an inspectorate, but they're actively looking into it, and they intend to do more. On the aspect of prescriptions, it's a legal requirement, Dr. Smith, that doctors put their name, telephone number, address. It's legal. As a matter of fact, last week at the Pharmacy Council, the deputy DPP said that if we don't have all parameters of that section that speaks to all the elements of a prescription, including the physician information, it is not a legal prescription. Therefore, the registrar of the Medical Council says, send them back.
Yes, I agree.
I didn't say it, That's what he said. He said if the prescription is not complete, send it back, and if we keep doing that, eventually we will get the standard where it should be.
Yes, that's what I alluded to when I made my talk earlier, because we can't get people coming in and registering properly, and therefore they're practicing outside of paying registration fees and outside of policing. Speaking to the medications that are sometimes in doctors' offices, when people set up years and years ago, there wasn't a near pharmacy, it was distant, that sort of thing. I could understand when it started, but now that the pharmacy has branched out into the area, you're not competing with the pharmacies. You might just need to start up the person for the night after the pharmacy has closed, and you're still practicing and the person has an urgent issue. And you're going to review them, it's a Friday, and you're going to review them on a Monday. But a lot of people don't have the pharmacology know-how. I'm coming into medicine with pharmacology from Chelsea College, London. And maybe that's why I'm able to speak to the pharmacists more or less on their level. But the interactions and the changing of the QRS and the SD complex and stuff like that, A lot of doctors don't have that in-depth knowledge, and therefore they cannot be competing with the pharmacists.
Hence the collaboration that we need.
Can I go now?
I'm just gonna, Mr. Houghton has been standing a little while.
Yes, thank you, moderator. Greetings to the panelists and greetings and good afternoon to my colleagues. We are on a panel discussion for pharmacist and physician collaborative relationship. I just want to say that we are all in the business of healthcare in Jamaica and globally, and the wellness of the patient is the final goal. Patient is ill, they go to the doctor, they get a prescription, they come to the pharmacist. So, from the illness is the problem, the solution is to get better. Whether in the short term, the medium term, or the long term. A big part of what we are discussing today goes back to the affordability of the service we provide. The affordability of going to the doctor and the affordability of going to the pharmacy. And that is why generics play an important part in today's world. And I just like to say about generics in Jamaica that our medication standards in Jamaica are first world. Both brand name and the generics, the regulations that supervise their importation for them to be in pharmacies is very, very high standard. So I do not see a problem with generics in Jamaica. And if there's a problem, we must document it and send it to the authorities. I don't think we are doing it if we see the problem. So we can't just speak generally and say that some generics don't work. The final point I'd like to make is that the compliance of taking one's medication is important. Depends on what the illness is being treated, and sometimes a person, when they are hypertensive or diabetic or some other chronic illness, it is for life. And therefore, between the pharmacist and the doctor, there must be some collaboration to ensure that that person can afford to be on the medication for as long as they need to be to keep them well. And that is where the collaboration is most important. So the trust between the physician and the pharmacist, I agree, is paramount. Those are my points. Thank you
so much, Mr. Gordon. Unfortunately, we are in a time crunch. I can only take one more question. I am going to invite, I'm sure you don't want to be here all day. I am going to invite all of your comments to be submitted by email. We can submit them to the Pharmacy Council, to the Pharmaceutical Society of Jamaica. Let's work to see if we together can have another CE where we can work on this issue again. So just one more point, please.
I am actually speaking on a matter that she's here to talk about.
Could we have her share at the point, please? Thank you.
Okay, good afternoon, colleagues. Very, very good that we're having a panel discussion as this one. And my practice is actually in Westmoreland, and it's on the same note as it relates to doctors stocking. Now, my point is that the distributors, who all have pharmacies, I've worked in distribution as a pharmacist at Gators Grant for a couple of years. They are seeing all of these orders that the doctors are actually putting in. And so they are facilitating the doctors. I mean, in my area alone, you have doctors stocking things like, some of the orders come to the pharmacy in error. You look, an order coming with 100 alprazolam for a doctor's office, 100 bottles. I mean, they are buying even more things than the pharmacists are buying. Yes, Mrs. Cox, we should write and report to MAJ, but I'm also saying who regulates these orders when they come in from the distributor, because they certainly are facilitating the doctor's stocking. So that's my point.
And I think as highlighted, it's an issue that is being worked on. Dr. Smith had mentioned that the association will work on it.
Thank you.
Yes,
Thank you for this
Robinson.
opportunity. I just want to share that as it is now at UE, final year medical students spend approximately 4 hours. 2 hours for a pharmacy lecture, 2 hours at a pharmacy site in their training. That's out of the Department of Community Health and Psychiatry. And one of the objectives of that kind of interaction is to improve collaboration between physician and pharmacist. I want to publicly thank all the pharmacists who have been facilitating the medical students to do a 2-hour session in their pharmacy. I am very appreciative of all the panelists' contribution, in particularly Dr. Bent, when she spoke about the generic drugs, generic substitution, if I may say that. One of the points I make strongly in the pharmacy session that I'm privileged to teach is that, or to facilitate, that's a better word, I made the point that the prescription is a communication tool between the physician and the pharmacist. And what is very common today, on the scripts on which we write the prescription, the medication orders, there's a little checkbox, generic substitution, yes or no. And I remember as a younger pharmacist, when some doctors prescribe, if they did not want a substitution, they would put in red and bold, do not substitute. And I'm saying to the medical students, you're the prescribers. You can dictate what you want. You're communicating to the pharmacist that you don't want any substitution here. So you may have started the treatment in the office. Like she said, I like the point she made about the trial period. Yes, that was it stand out in my mind. Because you want a trial period, you want to see how the patient is doing on a particular patient. And I think for us as pharmacists, we want consistency. I wouldn't want my patient on Apotex this month, and then another generic, and another generic, and another generic. So together, saying probably to the Medical Association of Jamaica, Dr. Smith, if we get to the prescribers, indicate to pharmacists if you want substitution or not. Even though we have a law that says generic substitution allowed, ask your pharmacist. It's not in our forte to say substitute without the physician's order, unless they have given us that directive. And I just want to endorse what Mr. Orton said about generics. It would not be on the market. My understanding about the Ministry of Health, Standard and Regulatory Division, the generic would not be on the Jamaican market if it has not satisfied the requirement. Thanks for this opportunity.
Thank you, Mrs. Robinson.
I'd just like to make the point that we, as physicians, they've spoken, as pharmacists, we normally forget the most important person in this whole equation, as a patient. Now, if patients are educated and patients are aware that they shouldn't go to a doctor's office and have a receptionist giving them prescription medication, a lot of them will make the right decision. And so the practice itself will be stopped in that respect. So as pharmacists, we're tasked under the Code of Ethics to educate our patients, and we need to do that as well. That's the point I wanted to make.
I just want to make a quick point, please. Much has been said about solutions that are needed in various areas, such as, stocking of prescriptions and items that are required on the prescription to make it legal. I just want to implore on whether it be the MAJ or the Medical Council, can you implore on the physicians to get stamps? That would solve our problem. As part of this, I think stamps are cheap enough. Everybody should be able to get one. That would solve a part of the problem. Yes. Pardon me? Okay.
You know, I don't endorse the stamp idea.
Oh, you don't? Okay.
No, I don't endorse the stamp idea. Several of my colleagues got stamps made for them by people as gifts for when they finish med school, which means somebody went to a company, had a stamp made without providing any credentials to verify that this person is a doctor. And a stamp was produced and given. When I went to get my stamps made, nobody asked me about my credentials. So anybody can make a stamp. So I don't endorse that that a stamp should be the solution.
That is true. But if we were to go along that tangent, every profession, whether it be law, pharmacy, whatever it is, would be leaning on that thinking. So I don't think it is fair enough to say because anybody can go in for a stamp, you don't really, it has to be signed nonetheless. So a signature goes along with it. You can even write your identification number again, your registration number again. Nothing stops you, but it clarifies, it solves the problem of us just seeing as scribbling or as a signature. Bear in mind that patients travel very far at times out of their prescription zone, so to speak. So a person leaves the university hospital, goes all the way back to St. Elizabeth, for instance. That pharmacist will not be familiar with the signature, so it solves that problem. It's just a problem we're trying to get rid of right now. And as part of the collaborative process, I think we need to get the insurance company in on this, because I realized that recently we can now put in University Hospital or wherever it is, and you get away with filling that prescription for the patient. The insurance company covers it. So we need to get the insurance company in.
Okay,
I think that is it for me. Yes.
All right, just to add my 2 cents to that, I can see both sides of the coin. I have been in a situation where with an established stamp, a patient was able to reproduce the signature of the physician. What I suggest, and I'm sure we had a discussion in one of our meetings, that stamps should not be made unless an individual can present at the company their registration.
Makes sense.
So there are ways in which
Yes.
we can work together for pharmacists as well as physicians, ways in which we can move forward in order to ensure clarity of signature and who we need to contact, as well as to protect the physician and the patient.
So you could make recommendations as to which company or companies we can go to. And last but not least, pharmacists, I implore you to all work together. If we are going to stand up against these incomplete prescriptions coming towards us, for us to fill, then we all need to make a stand that each of us is not going to fill a prescription if it is incomplete. Too often we see where some of our colleagues are trying to maintain standard and others come behind us, or at other pharmacies in the area, patients go there and they have their requests fulfilled. I think we need to get rid of that in order to lift the standard in the profession.
Thank you.
That's my 2 cents.
Thank you. And I know that we could go on for hours, but we have to move forward with the day. Again, I'm going to encourage all of us who have thoughts and ideas for discussion to pass that on to the relevant organizations. Let us know so we can organize CEs, we can sit and we can work out strategies to move forward. Again, I'll underscore the importance of collaboration. We cannot move forward without working together. Nurses, physicians, pharmacists, we have to find a way to do that. We need to be able to meet each other at a point where we understand and respect the other for our expertise, and use that to move our professions and patient care forward. So I applaud all the individuals who were able to share with us today. And I also want to extend thanks to all the members of our panel, Dr. Smith, Dr. Bent, Ms. Langley, and Dr. Russell. Thank you so much for sharing with us. Thanks for your expertise. And thank you for participating today.
Hello. A good section of us still have these.
Okay, customer service agents, could you just raise your hand, just stay seated, raise your hand, and they'll come and get them. All right, at this point, are you filing out? I had a speech prepared. Let me drop the speech. When you're ready? I had a dream that one day AJ and PSJ, doctors and pharmacists, prescribers and dispensers, white coats and white coats will work together for equal rights and justice. All right, everyone, thank you very much. You're at the coffee break now. I'd just like to do a quick presentation because some of our panelists have to go. All right, so normally we'd have someone come up and do this, but in the interest of time, they're all cool people, so I can do it this way. So. My love, you know. And Sarita, our moderator. Okay, thank you. You can give them a round of applause for a wonderful presentation, excellent discussion, and of course, we learned a lot.